Hello and welcome to the State Peer-to-Peer Learning Mobile Crisis Response in Rural and Remote Communities. Please note this meeting is being recorded. We recommend watching the session in speaker view to easily view the presenters by changing your view in the top right corner of your screen. Questions and comments can be submitted into the chat box throughout the meeting. You can also access closed captioning during the meeting by clicking on the closed captions icon at the bottom of your screen. And I will now turn the call over to Heather Cameron, project consultant with WICHE.
Okay, my first glitch. I'll say it again. Good afternoon and welcome. We look forward to this session today, to hearing about what's going on around the country and to hear your questions for our presenters. To begin our session, I'm going to introduce Dr. Belina Shaw. Dr. Shaw serves as a senior medical advisor and the Center for Mental Health Crisis Services liaison to the 988 Behavioral Health Crisis Coordinating Office at SAMHSA. Dr. Shaw is a triple board certified psychiatrist in the specialties of general adult psychiatry, child and adolescent psychiatry, and addiction medicine. Prior to joining CMHS, Dr. Shaw was the medical director for the Behavioral Health Division of Prince George's County, Maryland Health Department. She is a graduate of Yale University, the Johns Hopkins Bloomberg School of Public Health, and the University of Pittsburgh School of Medicine. Thank you, Dr. Shaw.
It's the day for not unmuting yourself. Thank you so much, Heather, for that introduction, and thank you to NASHBID for putting on another exciting and informative webinar. I love to listen in on these, primarily because not only are we sharing information, but we get to learn at SAMHSA really what the state of the field is and where everyone is going and what everyone's doing. And so I just always enjoy listening to these. And I also just want to thank the presenters for all their hard work and dedication to the space and really just doing and being our legs here at SAMHSA and really serving the people. And so I'm very excited for this topic, and it's actually quite timely as well as next week is the National Association of Rural Mental Health Conference. And SAMHSA is also currently finalizing a report to Congress on rural behavioral health. And we know at SAMHSA that 988 needs to be for anyone and anywhere, anytime. But we're aware the guidelines are much easier to implement in resource and population dense areas. And there are needs of rural and remote communities that are unique. And that's vital to actually really implement the vision of SAMHSA. We also know that there are major health disparities that are relevant to communities that are in rural and remote communities, as the suicide rates, for example, of farmers are higher disproportionately, as well as our American Indian and Alaska Native populations that are often residing in rural remote communities as well. Innovative strategies are really essential to fulfill the vision of someone to contact, someone to respond, and a safe place for help in rural and remote communities. SAMHSA actually just hosted a couple of months ago a policy academy where we had 6 local communities, and they were actually rural and remote communities, and it was not a statewide policy academy, but a local policy academy, and they brought together 6 local communities, connected them to their state leaders, and helped them to work through some of their key sticking points in 988 implementation. And about half of the teams actually did select of the 3 pillars of the crisis continuum, the mobile crisis pillar. So we know that this is a very important topic and a very important presentation. And we also know that it's really, this is a part of health equity for us here at SAMHSA. So as usual, we'll have the exemplar states followed by a level setting presentation by a broader national organization. And today that will be from Deborah Kupfer at the Western Interstate Commission for Higher Education, or WICHE. Deborah Kupfer has more than 40 years of public behavioral health experience as both a clinician and administrator, including 17 years as a senior consultant with the WICHE BHP. Additionally, she has provided technical assistance and consultation services with NASHBID and the NRI, or the NASHBID Research Institute. Advocates for Human Potential, and the Mental Health Colorado, formerly known as the Mental Health Association of Colorado, as well as several other entities. And currently, she's an executive board member for RMCP and serves on the executive board of the National Dialogues of Behavioral Health. Deborah has spent 25 years with the Colorado Department of Human Services, serving as the Mental Health Commissioner, Manager, and Director of Policy and Planning in Hospital Services for the Colorado Office for Division of Behavioral Health, and as a clinical therapist and adult division deputy administrator for the Colorado Mental Health Institute at Fort Logan. She has served as the SAMHSA Mental Health Block Grant Reviewer, Monitor, and Consultant for over 10 years, and as a national facilitator for AHP's Olmsted Community of Practice Initiative funded by SAMHSA. I'll turn it over to Deborah Kopfer. Thank you so much.
Thank you, Dr. Shaw. It's good to be with everybody today. And I'm going to start out by just explaining WICHE briefly. WICHE was created by Congress in 1953 in the Behavioral Health Program in 1955. And it includes the 15 Western states and the US Pacific Territories and freely associated states. There are other commissions that cover other regions of the country. We're just the West, and basically we are the Dakotas and West going into the territories. WICHE has a behavioral health program. We are the only commission with a behavioral health program, and that came out of the first president of WICHE said that we really need to make sure that our students have healthy, strong minds in order to be able to learn and benefit from the higher education programs. So pretty innovative back in 1953. But at any rate, we continue to work with the states and various stakeholders to optimize the delivery of behavioral health services with an emphasis on rural workforce, tribal, and other special populations and initiatives. Talking about mobile crisis and crisis services in general, as you know, the rollout of 988 and more comprehensive crisis services and systems is changing the entire crisis and behavioral health landscape. States and communities are challenged with delivering culturally competent crisis services, including the culture of rural and frontier communities. About 60 million people, which is 1 in 5, live in rural America. In rural communities, there's often a higher level of stigma and lack of anonymity, reduced privacy, and boundaries challenges. As many of you know, the people you serve are also the people you live by, go to church with, and see in the stores. Telehealth and integrated care can help alleviate this challenge for prevention, early intervention, and follow-up services, and potentially to support or reduce the need for mobile crisis services. One question for rural communities, given their challenges, is how can you build and sustain a responsive and effective behavioral health crisis service system? We often assume or hope that downsized or modified urban models will work in rural communities. However, without careful inquiry and evaluation, we don't know what modifications necessarily are effective. More studies regarding the models and fidelity of rural behavioral health programs, including crisis services, are needed. Advance the slide, please. I'm going to start with talking about the sort of the non-law enforcement mobile crisis teams. And the general operating standards for these teams is it's a 2-person team with 1 behavioral health clinician or professional or a medical professional and a paraprofessional, which could be a well-trained peer specialist or other types of community health workers. And they dispatch and respond in the community 24/7, intervene, assess, and de-escalate crises. They also engage and connect people to behavioral health support services and treatment on site, provide and arrange for transportation to a secondary location if it's needed, and follow up with a 24-hour response after the initial incident. However, this non-law enforcement model is a challenge for many rural communities. While law enforcement officers are not identified ideally as mobile crisis team members, they are often the crisis responder in many rural areas 24/7. But this is changing, but it's still a work in progress. There's also a lack of licensed clinicians, behavioral health professionals in rural communities, and there's limited transportation resources. A strength of this model, however, is that the team may be comprised of an EMS or EMT member along with the behavioral health or with a behavioral health paraprofessional, expanding the use of trained paraprofessionals to help offset some of the workforce issues. Next slide. As an alternative, the law enforcement co-responder model includes one CIT trained officer and one behavioral health professional or paraprofessional. And when a behavioral health professional is not part of the team, clinical oversight is provided by a professional, a licensed professional, often remotely. This model can be effective as an alternative approach because it does reduce cost, decreases criminalization of individuals with behavioral health disorders and crises, and supports people being treated in the least restrictive environment. However, challenges of this is that once again, it requires workforce, including law enforcement agencies, to have the capacity to be able to support this. An example with a few numbers is in Wyoming, they have approximately 1,700 sheriff and patrol officers for 98,000 square miles versus Ohio, which has 24,000 officers and less than half the square miles to cover. Another challenge can also be the financing of the model and needing to have the resources to sustain if, when involving law enforcement, but some of the other responders. Another model, advance the slide, please, is one in which the law enforcement officer is not a team member. This may be an option for rural frontier communities with limited behavioral health professionals and some economic constraints. With this model, the first responder providers request a mobile crisis team after encountering someone in need of assistance. The team is comprised of non-licensed, non-clinical individuals that are well-trained in crisis interventions. And again, they may be behavioral health support specialists, community health workers, or others. Team supervision and consultation is provided by a behavioral health clinician. Given travel distances and coverage, they are not expected to be immediately or quickly on site. They may be called to known people to connect them to social services or other programs. They may also be used to provide a warm handoff when first responders are prepared to relieve a scene. And they may assist people who may benefit from assistance or follow-up following the intervention. There's a lack of public research regarding the efficacy of this model for rural and frontier communities. However, other research regarding behavioral health support specialists, peer specialists, community health workers, and others indicate that staffing with this approach has promise for smaller populations with limited workforce and financial resources to sustain around-the-clock crisis services. Next slide, please. This will not be a surprise to probably many or any of you, but the white areas of the map show the metro areas, but there are significant workforce challenges across the country. And these are behavioral health shortages are especially significant in the regions west of the Mississippi. More than 60% of behavioral health professionals live in professional shortage areas. And more than 65% get their mental health care from a primary care provider, not a behavioral health provider. 90% or more of all psychiatrists and psychologists and 80% of master's level social workers exclusively work in metropolitan areas. Mental health crisis responders for most communities is law enforcement. And again, this is changing. Specialty providers are highly unlikely to be available in rural areas. And in most settings, there are generalists with behavioral health providers doing their best to address the presenting needs of people who come to need services. It's important to note that with telehealth and the growing use of telehealth for both workforce development and crisis service provision, that there are more opportunities for services to be available in these rural communities. Next slide, please. Some additional challenges that are faced are demographic, geographic, and economic. The training and education of professionals and paraprofessionals and non-clinical staff specifically to work and serve in diverse or remote rural communities is one strategy that to address the overall demographic challenge of mobile crisis services as well as behavioral health care overall. Regarding telehealth, while there are still significant broadband and internet deserts across the country, this is changing, even in light of some federal funding this year with awards to build internet connectivity and speed in rural areas. So far, I think it's about $8 billion in funding. Looking at funding and sustainability, the cost of round-the-clock sustainability is not easily sustainable. Only 6 states currently have Medicaid coverage for mobile crisis services. I tried to find all 6, but I did find Oregon, New York, Kentucky, and California. And that's certainly, and again, there's state level, Medicaid approved waivers. And so it does depend on the models in those states and what is approved for the reimbursement. But at least that's a start to get some mental health crisis services supported with some Medicaid dollars. But they do typically require the 2-person behavioral health team, a behavioral health professional, or a trained paraprofessional. So they are sticking more closely to the well-known national model for mobile crisis services. And so services and sustainability will require, I think, getting started as well as ongoing provision of services, not only looking at Medicaid and state dollars and county, but also looking at other funding sources through foundations and other means. Next slide. In closing, I'd just like to say that the planning is needed, as you all know, for rural mobile crisis development and the success of programs that are rolled out. What works in urban areas may not necessarily work in your region. Access to unique resources and parameters of your community to determine what is reasonable is important. Need to consider workforce, geography, road systems, climate and weather conditions, broadband connectivity, referral and support provider types, first responder capacity, and many other factors. Also, the deployment triage strategies noted in this slide may make mobile response more feasible in some of your rural and more frontier communities, and could be considered as part of a strategy. And using regional approaches instead of, some states are very county focused in how they operate some of their behavioral health services, but trying to look at regions and combining some of the resources may also be helpful, especially in areas where geography, transportation is not as big of an issue. The collaboration, I can't underscore the importance of collaboration. And those of you in rural communities, you probably already know so many of the people who work with you, but collaborating with the community stakeholders for input, support, and buy-in for developing mobile crisis services is critical. Should engage law enforcement, firefighters, EMTs, healthcare providers, and county and state organizations. Remember, the health department, farm bureaus can be a very, very good resource. The schools, universities, cooperative extension offices. There are so many possibilities for collaboration, and don't try to think too narrowly about that, because they might miss some opportunities that you could really benefit from. Based on a WICHE recent scan regarding rural crisis services funding and workforce, crisis prevention and early intervention models may be the most attainable, pragmatic, and culturally attuned and financially feasible solution to reduce the need for mobile crises in rural areas, as well as other regions, and is worth developing and expanding. And I say this because certainly we're focusing on mobile crisis, but ideally we would be able to connect with people before they are in crisis. And so looking at more, I tend to not use the word continuum of care, but looking at more of a constellation of care and opportunities. And while it's important that we develop the mobile crisis services, don't forget to look in front of the need for that. And let's see if there's some opportunities to to intervene and not end up needing the services. And with that, next slide. I think I forgot to say a next slide. Nope, I didn't. All right. Thank you. In closing, I just want to say for those of you in rural communities and rolling out mobile crisis services, thank you so much for all the work that you're doing and your willingness to learn from each other and try to figure out how to move this needle a little bit farther to meet the needs of people. Thank you. And I will turn it over to Heather, I believe now, to introduce our next presenters.
Thank you, Deb. I want to take 1 second to apologize. When I opened, I didn't talk about questions. At the end of this session, we'll have quite a bit of time to answer your questions after our next 3 presenters. So please feel free to put your questions in the chat box or hold on to those and enter them after you hear all 3 speakers. We are monitoring what's going into the chat box as well and just making note of that. So thanks again for your participation. And next, I am going to present 3 folks, one from Texas, talking about the Texas program, and 2 from Utah. I'm going to start with our speaker from Texas. Lucrece Pierre Carr is the director of the Crisis Forensic and Jail Diversion Service Unit with Texas Health and Human Services Commission. She oversees the program implementation, policy, and procurement of statewide mental health crisis, forensic, and jail diversion programs. Lucrece has overseen the successful expansion and implementation of these programs across Texas since her state employment began in November of 2012. For approximately 12 years prior to working for the state, Lucrece provided direct mental health services in outpatient mental health and permanent supportive housing settings, and served various populations, such as people with serious mental illness involved in the criminal justice system, who are elderly and with a history of homelessness. She earned an MSW from University of Texas in Austin and a bachelor's degree in human services from St. Edward's University. Although a native of Chicago, Lucrece loves living in Texas with her husband and her 2 children and her cat Cannoli. And I hand it to you. Oh, wait a minute. I'm sorry. I'm going to go ahead and introduce the Utah speakers before you begin, Lucrece.
That's right.
From Utah, joining us from the state of Utah is Leanne Huff. Leanne Huff started her career in crisis services in 2004 at Valley Mental Health Community Treatment Program as a supervisor providing crisis intervention to individuals with serious mental illness. She served as the mental health regional coordinator for a Utah crisis intervention team program for Salt Lake County, helping to coordinate CIT trainings, as well as providing suicide prevention, intervention, training to law enforcement in the CIT Academy. In 2011, Leanne took a position with University of Utah's Mobile Crisis Outreach Team. In this role, she worked collaboratively with community stakeholders to roll out the robust new set of crisis services to Salt Lake County residents, as well as providing crisis intervention to individuals in the community. In 2012, Leanne joined the State Division of Substance Abuse and Mental Health as a program manager for adult mental health. In this position, she provided oversight and monitoring of adult mental health services in Utah, promoting behavioral health integration, early intervention, and recovery. Currently, Leanne is program administrator in the Department of Health and Human Services, where she's responsible for implementing, evaluating, and monitoring Utah's mobile crisis services. And finally, Leanne Laudumas will be joining Leanne in a presentation around Utah. Anna is a licensed clinical mental health counselor in Utah who has worked in Central Utah Counseling Center as a public community mental health agency for the past 25 years. Rock on, Anna. She is currently the director of crisis services for her agency, and in that capacity also supervises its mobile crisis team, which has been active since July 2021. And with that, we hand the microphone over to Lucrece.
All right. Thank you so much, Heather, for the introduction. I am going to be sharing our array of services in Texas, but particularly MCOT services in rural communities. First, I'm going to give an overview of our crisis service continuum here in Texas. We work with 37 local mental health authorities and 2 local behavioral health authorities that operate an array of crisis programs. Some programs are community-based crisis programs, which entail some facility-based options such as crisis stabilization units, extended observation units, crisis residential units, and crisis respite units. We also have some non-facility-based programs such as crisis intervention response teams, some mental health docket programs, and some triage programs. These services are available based on community needs and funding availability. We also have some inpatient psychiatric bed programs where local authorities subcontract with private psychiatric hospitals to provide inpatient services. We have 5988 Suicide and Crisis Lifeline call centers here in Texas that answer our calls locally, available 24/7 in all 254 counties. We also have local crisis hotlines, which are also available 24/7 at all 39 local authorities. These hotlines serve as our first point of contact, offering immediate response, and they provide crisis screening and linkage to appropriate services. We also have some mental health deputy programs where local authorities subcontract with local law enforcement to deploy a certified mental health deputy to address people in crisis. We also have some rural crisis response and diversion programs. And of course, we have MCOT, mobile crisis outreach teams across the state that are available 24/7 and at all 39 local authorities. So these MCOT teams provide a combination of crisis services to children, adolescents, or adults, including emergent care services, which requires a 1-hour response time, urgent care services, which require an 8-hour response time, crisis follow-up, and relapse prevention. The MCOT team is comprised of 2 or more staff providing psychiatric emergency care who go into the community to begin the process of assessment and provide recommendations for the least restrictive treatment environment. The MCOT team composition in terms of staffing credentials varies based on if the location is rural or urban. MCOT responds to calls in the community and collaborates closely with community partners such as law enforcement and local emergency departments to ensure behavioral health care needs are appropriately addressed. Again, these services are available 24 hours a day, 7 days a week, and they are available in our 254 county state. Now, MCOT in rural communities in Texas. So of the 254 counties in Texas, 233 are considered rural. 27 of the 39 local authorities serve rural populations. And so some unique challenges that we've just learned through our work, it relates to one, accessibility. So there is limited access to resources, including housing and shelter and food, inpatient psychiatric treatment and substance use treatment in rural areas. And inadequate public transportation is a barrier to outpatient treatment, especially for those with limited means. Another challenge is response time. Now, I noted this response times earlier. The response times can be negatively affected due to distance in rural areas, which delays mitigation of crises and appropriate treatment. Another challenge, which many of you know about, is our staffing and workforce shortages. While workforce shortages are seen throughout the state and nation, rural areas are especially affected. And then another challenge is stigma, related to stigma. Individuals may be more hesitant to request crisis services in smaller communities. Individuals may feel a lack of anonymity within rural areas where staff frequently live in the community in which they serve. And communities with older individuals often feel that behavioral health issues should be dealt with in private. So a major emerging solution involves technology. So phones or tablets are provided to law enforcement in the field. Law enforcement are given tablets and have the ability to download an app on their work issue cell phone. When law enforcement is on the scene of a mental health crisis, they can contact local authority staff through the tablet or app for assistance with crisis assessments. Some emergency rooms are also equipped with this same technology, which allows individuals in crisis to be assessed more quickly and connected to appropriate services. This technology decreases the amount of time the individual is waiting in the emergency room or in the community with law enforcement before receiving appropriate services. And the ability to complete remote assessments allows MCOT to quickly connect individuals to appropriate services while also freeing up valuable resources within law enforcement and emergency rooms. And so that concludes my portion. So now I'm going to pass it on over to Leanne. Thank you.
Thank you, Lucrece, and thank you, Heather, for your introduction. If we could pull up the next slide. I'm just going to give a very brief overview of our mobile crisis system as a whole before I pass it off to Anna to talk about her programming. Utah has one 98 Lifeline affiliated crisis call center, which has the ability to dispatch mobile crisis teams statewide. We have 13 local mental health authorities that receive funding to provide mental health and substance use services to their communities. And each of the local authorities has a mobile crisis outreach team. In rural, we wrote after legislation passed that our mobile teams be a licensed clinician, preferably a peer support specialist. But as you can imagine, with the shortage and challenges with staffing and just the rural areas being different, we have a lot of exceptions to that rule. On this map, you can see that the 13 local mental health authorities are identified by color, and central and these catchment areas, many of them cover several counties. And Central Utah Counseling Center, which is located in Central Utah there, and which is purple, has 6 counties that these teams are challenged with covering, and all these counties are considered rural. I'm going to hand it over now to Anna Ladamas to talk about how she's implemented mobile crisis teams in her area of Central Utah.
Thanks, Leanne. So in that Lavender area that Leanne just pointed out to you, that's Central's coverage, I just wanted to let you know that the geographic area is about 17,000 square miles, 17,007 square miles. But the population within that area is just under 80,000, about 79,526 people there. So next slide, please. This is just kind of a breakdown of what we've done for our particular team. As mentioned in my bio, we're kind of the toddlers. We've only been doing this for about 2 years now, just over 2 years. And so the creative way that we've dealt with staff shortages has been to incentivize the therapists who are willing to be on the team, that they really only work 6 months out of the 12 months of the year. So our scheduling is that we have 3 therapists on for a week at a time, and then they have the following week off. Most of our response is with 2 therapists, and most of it is face-to-face on scene, with quite a percentage of that with law enforcement support. And then we also have 3 case managers that cover our kind of sub-geography areas and provide support with 1 therapist during business hours. So we have found that has been a way for us to be fully staffed, and even with the shortage, to have other therapists who are interested in joining us. I thought it might be of interest for you to hear some of our statistics for the previous fiscal year. This is probably actually about 11 months worth. I don't think we have all of June's in yet, but we have provided a total of 955 services, including both initial deployments and follow-ups. The vast majority are Medicaid, 60% or so. As far as age, most are adults, 27 to 64. Second to that is adolescents, 13 to 17. The reason for the deployment is most often suicide risk, about 31%. Most of the settings is in the home. The referral source that we receive most from is our own public mental health agency. Dispatch or law enforcement accounts for about 25% of our referrals. And our median response time is about a quarter of an hour, which, you know, has been fortunate that we've been able to, in those sub teams, have workers who live kind of spread out in those geographic areas so that there's always someone relatively close. And the average duration of our service is about 3 hours. Would you go to the next slide, please? As mentioned, some of the same kinds of rural challenges exist for us. The lack of cell phone coverage in all of our areas. There are stretches of road where we have, 15, 20 miles of no coverage just because we are so rural. And also that, estimated time of arrival, the travel. We are starting to use, some telehealth, and we'll probably be moving to that more. But at this point, the vast majority of our deployments are face-to-face on scene. Some of the successes that we found is that we have much better relationships with all of our county sheriff's departments and our city officers than we did previously. And I think some of that too is that there's an overlap and a connection to our crisis intervention training for law enforcement. Something that we're working on for this fiscal year has to do with actually utilizing our EMS, our county and city ambulance folks who are willing to be trained and certified so that they can actually be the ones to wait on scene for our MCOT team members to arrive, thus reducing the need for law enforcement officers and deputies to wait until we can get there. And so we're excited to see how that increases our ETA or improves our ETA. And I think that's all I have at this point. Looking forward to your questions, and I'll turn the time back over to Heather.
Hello, and thank you all for your presentations today. We have questions coming in. It looks like we have about 110 folks participating. So hopefully we're going to get a lot of questions, and some of you have similar questions. If it's okay with you, I'd like to go ahead and feel free to raise your hand when you would like to ask a question or get noticed within the group. But Gordon Shell has asked a couple questions. One is regarding, is a master's required or is state funding allowed without having a master's? Is a BHA allowable? And the other was for Utah, and your response time is in that 15-minute response time, is that phone or in person? So if you want to, do you want to start with that question, Anna?
Yeah, most our therapists are all clinically licensed, therapists, and I'll let Leanne weigh in on, if that's a requirement of all MCOT in our state or not. But we always have at least one in order to provide and to bill for the actual MCOT service. One of those needs to be a licensed clinician, a master's level person. Is that statewide, Leanne?
Well, that's correct. We have a bundled rate for Medicaid. And in there, we defined a mobile team as a licensed clinician and a paraprofessional who they have to respond together to get that rate. However, we do have areas that have a different makeup, and they'll send 2 case managers out. There's always a licensed person on duty or on call who can be available telehealth in those areas. We strive to have a clinician go, but we definitely have different makeups. But when they are different, then they can't bill Medicaid. They would be able to kind of spend down our legislative funds that we give them.
And as far as the second question regarding the average 15-minute ETA, that is primarily face-to-face. Out of those 950 odd deployments that we had for last fiscal year, only 30 of those were via telehealth. So the vast majority are face-to-face. And again, it's because we're fortunate that we have MCOT team members who live close to those main areas. They're spread out enough that we usually have someone right there close by.
That's impressive. Lucrece, did you want to respond as well?
Sure. And so in Texas, for our MCOT teams, we do have requirements for a master's level for in our urban areas. I mentioned earlier that the composition of the teams vary based on urban and rural. And so there is an expectation for the urban that there is a master's level person available on the team for the diagnoses and things of that nature, and then also a bachelor's level person. And so in the rural areas, in terms of the daytime hours, that's not so much a requirement on a master's level for the on-duty hours, but for the on-call, there has to be a master's level person available.
Okay, thank you. A question did come in from you, Lucrece. If you have a document that you can share that shows how you categorize crises for response within an hour versus 8.
It's in our Texas Administrative Code rules, which is our rules, so I can share the link.
Great.
Yeah.
Thank you.
Mhm.
Another question coming in regarding actually, Megan's rescinded her question. Thanks, Megan. It was around, does it always have to be a licensed mental health professional? I'm looking to see what questions are coming in. Okay, we're being reminded of this. Somebody asked in the beginning of the presentation, I'm sorry, I didn't catch who asked this. What messaging are you recommending for people who strongly do not want law enforcement showing up on scene? Although in some communities, after hours, holidays, late at night, law enforcement does need to be there. What messaging do you use to folks you're serving? Want me to pass it to you, Anna?
Yes, I don't know that, we have any like messaging per se, but I do know that we encounter often community members who don't want police. And so depending on the situation, in crisis work, each situation is unique and different, but we will often have law enforcement available close by, especially if it's a known client. I was actually just with our MCOT team at a situation like that yesterday, where they were close by, but they couldn't be seen through the window or through the door as we approached this person to try to talk with her and assess her.
Thank you. Anybody else want to respond to that? Lucrece, do you want to respond?
I would say we particularly don't have any messaging either that I'm aware of. So I don't think, and I'm trying to understand the question, but I don't think I have anything more to add than that.
Okay.
We don't have our messaging, like what we promote is, not to have law enforcement unless it's a safety issue. But I can't speak to the individual local authorities who might be taking a call where someone is saying, I don't want law enforcement. But as a state, we are promoting to, if you can go without law enforcement, then that's what we prefer. But if safety is an issue, of course, always utilize that resource.
Heather, I have a comment too. One is often the first on the scene are firefighters. versus law enforcement, and having them well trained in crisis response and intervention can be very helpful and doesn't give the same feel of having a law enforcement officer there. They certainly need to have specialized training, but that's an option consideration in some rural frontier areas. The other thing that I've heard about recently is one very rural community that I was talking with. They cannot have law enforcement respond, and that's because of state regulations around mobile crisis while they're on duty. But if any law enforcement officers in communities want to be trained in rural crisis mobile response, they can moonlight and help cover off shifts. And so that may or may not be a consideration. They would be, considered a paraprofessional and certainly not leading everything, but they would also have, especially in the more rural areas, availability through telehealth to a behavioral health clinician while on site. So some of these are just creative approaches and thinking outside the box. And sometimes if you've seen one rural community, you've seen one, but that's where it's real helpful to work with different community partners and sort of see where the opportunities may be and who may be of interest. And when you know a lot of your neighbors and other people, as they learn more about the benefits of this and keeping folks out of jail, out of emergency departments, they may be more willing to step up and look at, thoughtfully at some other options.
Thanks, Deb. We have questions coming into chat, but Kevin Stevenson has his hand up. Kevin, would you like to ask a question?
Sure. Greetings from New Hampshire. We are very much in our infancy here with mobile crisis. And there are some growing pains, as you might expect. One of the things that I was curious about, for those of you who these programs have been established for quite some time, one of the things that my catchment area and some of my colleagues are struggling with is that it's not really diverting people from the ERs as much as it was anticipated. So any thoughts, hints, tips, strategies about how we can actually help the program get to where it's designed, what it's designed to do, i.e. divert people from the ER, would be really helpful, because in the data that I did for my team a while back, we're able to discharge 52% of the people we see in the ER. But the bulk of our dispatches, if you will, are still to the ER, because in our communities, for those of us that haven't been doing mobile crisis, that's where people were taught for decades to go when they weren't well. So just be curious about any thoughts on that you might have. Thank you.
Something that we've done that I think has helped with that, because we also have had the same system for my area, for Central Utah Counseling Centers area. We don't have any receiving centers yet. We don't have any access centers yet. So the ER has been the go-to place for any community members, to go when they're in crisis. I think all of the training and collaboration and things that we're doing with law enforcement is what has reduced the number going to the ER first. Instead of showing up the ER and then deploying MCOT, which does happen sometimes, most of our calls that used to be at the ER are now coming to us from the community, where the officer is at the home, at the store, wherever it may be. So we're catching them before they get to the ER.
And I would add, for Texas, we do have programming, different programs. Of course, there are less available in rural areas across the state, but there are local relationships and setups between the local authority and whatever that county is, where some of these relationships until our law enforcement can just directly, instead of sending someone to the ER, go to one of these types of facilities. And so we've gotten some additional funding through our last legislative session to expand more of these programs. And so that's promising in terms of having more of these diversion type programs, so that individuals don't need to go directly to the ER.
Thank you. I want to know Dr. Shaw would like to come in for a sec.
So I just wanted to jump in. I think I've had another meeting for a second, but so I missed some of the communication. But I think that the two themes that have been going on between the two topics are somewhat could be possibly linked as well. I know I've talked to Monica Johnson, now the new director of the 988 Behavioral Health Coordinating Office, and she uses the example that, you know, that her state has had well integrated mobile crisis and mobile dispatch for a very long time. And during the pandemic, there was a shift to telehealth and some splitting of teams sometimes, possibly as well. But I do know that there was a shift to telehealth. And she noticed that although there was still a strong increase and there was still a strong standard of response times, that the dispositions were different and fewer people were being diverted. And so I think that, you know, it's definitely a struggle and you know, 6 of one, half a dozen of the other when you think about staffing and staffing models. But if you think about it, if the clinician, if you're having, say, a licensed clinician in the emergency room who is doing the evaluation for disposition, and that same standard of clinician is one of your core responders on the team, then they should be able to do a similar evaluation in the field, and you could possibly have a higher rate of dispositioning, staying back, of people staying in the community at the mobile crisis level. So that is one of the strengths, and I do definitely hear, you know, the concerns around wanting to have, you know, extenders and people with lived experience in the community, and I think it's definitely vital for engagement and as well. And I know that obviously there's a clinician shortage, but you know, there are the strengths of clinicians. You know, when you think about the disposition and the liability that they can take on with saying that somebody who said that they wanted to kill themselves, but they could do a safety assessment in the field and keep them at home, versus if they're not on site, they're going to be less apt to make that judgment call, or a peer, you know, or a unlicensed person is unable to make that judgment call. So those are just some of the trade-offs that have to be made, and they have to be made for, you know, each individual jurisdiction. But I would just want to think about how to link some of those two discussions there.
Thanks, Dr. Shaw.
Kevin, the other piece I would add is that this is a developmental process. Colorado has had a statewide crisis line for a while, and several years has been dispatching mobile crisis. And, you know, hate to say it out loud, but initially the mobile crisis dispatch went to the emergency department in many communities. And so, you know, it takes training and education and comfort and some success stories to sort of start making a turn in that. So you all, you know, you mentioned you're in your infancy. You know, toddler life is not that easy either. So, you know, learn from what you're doing. It sounds like you're tracking the data, so you know, where people are being served and where they, you know, end up. But maybe trying to make that a metric that you really track closely to see if you can start moving the needle a little bit going forward.
Yeah, and I think part of the other issue is that, you know, a lot of our people aren't ending up in the ER because law enforcement's bringing them there. They're ending up there because they've taken themselves there or family members have taken them there. Sometimes they arrive via EMS, sometimes via law enforcement, but by and large, they're taking themselves there. And you know, once they're there and we're able to discharge them, we say, hey, call this number next time and we can get a team to you, but that doesn't really help the immediate situation, right? So, and we've advertised it. I mean, it's not for a lack of advertising, but it's not catching on quite yet. I mean, we're still less than 2 years into this thing, though. It just went into effect in January of 2022. So I'm optimistic that it's going to get better, but I'm just really trying to find a way, like you said, to drive that needle in the other direction. And
Thank you all. Well, it's fun when you go from toddlerhood to adolescence. So you can look forward to that, Kevin. There's a question about recommendations for training. What are some specific trainings for firefighters and first responders to help them be prepared? Anna, you referenced this in your presentation.
Yeah, but I'd like to volley it to Leanne.
Okay.
And so we actually had legislation passed to train EMS and paramedics on similar to CIT, and we have movement with that, and we have some interest. We did a needs assessment, but we're having EMS pilot the CIT program, and we're trying to integrate to see if they can join that, and then we would develop different scenarios for them. So we're in the process of, and Anna's going to, some of her EMS are actually going to come to our crisis worker certification training, because in legislation, every crisis worker in our state's required to take 40 hours worth of training to become a certified crisis worker. And that's a statewide training. And so they are going to come join that. And then CIT is another option, but we're currently in trying to hone that down and get feedback from them on what they will think will be helpful. But I do think, because so many of these states have CIT's been around for a long time, I do think that's an easy way to have people, have EMS or firefighters join that versus recreating that with.
What about services specifically for children, adolescents, families? Can any of you speak to that work, perhaps starting with you, Lucrece, in Texas?
That is emerging for us. And so we are actually through this legislative session, this monumental past legislative session we just had, we will be focusing on youth and putting up YCOTs across Texas as well. We do have a children's mental health team that's not my area of expertise, but we are looking to have these specialized MCOT teams across Texas. So that is new and emerging for us.
Thank you. Anything from Utah?
We have implemented SMR, stabilization and mobile response, for adolescents, and we don't have it in every area of the state, but we have it in a few of the regions, and they are responsible for responding to, MCOT can originally respond to the crisis, but if it looks like they would benefit from the SMR, they would then connect them with this group to then follow them and provide in-home services, and they can also respond to crises. So that's something that we are doing in Utah.
Thank you.
Heather, there's also some rural communities that have in their school system, middle school and high school primarily, behavioral health staff that can help educate the youth as well as the family members. And some also have well-trained younger peer support specialists that also provide in-reach to the schools and can help work with the families. And they can also be a method of communication and support. So, I think it's, again, a lot of this is evolving. There's not good data saying what's working and what's not, but there's a lot of good efforts out there to be creative.
Thank you. Question just came in up in chat. Could all of you talk more about how to handle the nature of small communities with neighbors and friends being on the mobile crisis team? Who wants to speak?
Yeah,
Andy, you're
we
smiling,
certainly
we'll go with
experience
you.
that challenge at times. Even though we're small, we try to accommodate for those dual relationships. If someone recognizes a name or a location, we will often try to keep that team member from being the one to respond, but it's also unavoidable, so just having that open discussion between that particular team member and the client that we're serving, the family that we're serving, to reassure them, of confidentiality and all of those other kinds of things. But, when we're so that small, those few people, it's unavoidable.
Mm-hmm. And do you do training with your staff around that and how to handle that?
Absolutely. Yeah. Yeah. We have annual training around those dual relationship issues and ongoing discussions around that.
Mm-hmm.
Another opportunity is to work with the community healthcare providers, and this is getting more into the early intervention and supports and letting them know that, say 988 is available for mobile crisis dispatch, but it may be somebody who responds that you will know. And, so at least the person, if they're, likely to have a crisis or, just want to warn them just in case, at least know that they may see somebody. And so it's not as much of a surprise.
It ties into a question regarding burnout too, and protecting your crisis staff from burnout. And them having their privacy as well, correct? So can you, how are you handling safeguarding against burnout? Just opening it up to Leanne, you want to say anything?
And we do address that in the 40-hour training. We have a whole presentation on self-care and self-awareness and the potential for vicarious trauma and burnout. So we do it, we have that part of the overall training, but we get feedback from all of our teams that is a serious issue. And I think we need to do more for them.
Mm-hmm.
For our team, you know, we do make sure that there's debriefing that happens, you know, immediately following, especially the ones that are, you know, a little bit more difficult or a little bit more emotionally laden. You know, we're encouraging that and almost pushing each other to do that when we see those kinds of things happen. We also, you know, allow employees to say when, you know, to say, I need to take a nap, or I need to be off the call roster for 6 hours, or whatever they may need. So just a lot of flexibility, you know, and trusting them to kind of assess their own mental status and let us know when they need that additional assistance, I think has helped a lot.
Mm-hmm. Chris, did you want to say something?
I would just add, I mean, I agree with all of that. And then the importance, and want to emphasize the importance of supervision as well. Ensuring that those supports are there so that they have someone to talk to about those issues that they're going through.
Mm-hmm.
It's tough work.
The question just came in for Utah. We're going to go into a little bit of workforce discussion, I think, in management. What does the 1 week on, 1 week off for the therapist team in Utah, how does that help with burnout?
I think it's primarily because they know, even on a very busy week, you know, where they may have been working overnight or had, you know, 16-hour days, that 7 days in a row is coming. You know, they mention that often, that's what gets them through, knowing that they have an entire week. And I mean, they're completely offline for that week.
Mm-hmm.
And also because of the way their schedule is, they still have, you know, their annual leave that they accrue, their sick and vacation and such. And so they can schedule their vacation and have up to 3 weeks off at a time because of the way that's set up.
Mm-hmm.
And that helps tremendously too.
Mm-hmm. What about recruitment strategies, given the workforce shortages in the behavioral health arena? What kind of workforce recruitment strategies have you all employed?
I would say in Texas, because we are contracting with our local authorities, so they are doing that work. But we have we've heard about sign-on bonuses to kind of increase interest. Some of our some of our rural communities struggle, particularly those that are near urban areas, because they can go to if they're really close to an urban area, they can go there and get paid higher salary. So sign-on bonuses have been a big thing that we've heard about. And when we have funding to provide to the contractors so they can increase salaries. And also, again, the supervision has been, an issue in terms of just that needs to be in place too, to ensure that people have someone who is monitoring that they can talk with. But for us, the money, the bonuses, paying them adequate salaries for the work that they're doing, the hard work that they're doing.
Mm-hmm. Mm-hmm.
We also offer those sign-on bonuses. We also offer, because we're rural, all of our sites are National Health Service Corps so that they can get the repayment of their student loans and things like that. That's another recruitment piece. And we have often recruited from those that we know are very interested in and experienced with crisis work. Several of our team members worked previously as emergency room or hospital social workers, crisis workers. So we have done some recruiting from, like I said, those that we know already love the work and have experience in the work.
I've also
Sorry, am I frozen or was it just Deb?
I think it was just,
Well, we got it's also out of her. So Leanne,
One
did you
thing-
want to say anything?
yeah, I think some of the areas are doing different things such as sign-on bonuses and definitely having to increase pay. It is such a stressful job. And one thing we talk about a lot is that crisis work really is unique, right? It's either people like it or they don't like it. One thing we've done is we put our 40-hour training in universities, Weber State, and we're trying to get into the University of Utah to kind of track people earlier on as these are potential jobs. And we're looking at paraprofessional sort of jobs and paying more in those positions as a case manager.
Can you all talk a little bit about the culture of rural community cultures and how that is important in keeping in mind your mobile crisis response? You want to think on that one for a minute? How about in Utah or Texas? Are you serving any tribal nations? And Lucrece, are you serving a high migrant population, actually?
I know we're serving tribal communities. I'm not sure about the migrant, but the tribal communities, that is definitely a unique culture. And we have I believe 3 in Texas. And it is, I'm just thinking about our work with 988 and trying to ensure that they're tapped in and they have different processes and just getting to know them. So yes, it's very important to understand what the culture is, and we respect that. We just communicate to make sure that they understand the services that we provide. So it's an ongoing challenge because each tribe is different. And so it's still an ongoing challenge with us to understand the differences, but we do have some liaisons. We, again, like I said, we respect them. We just want to make sure that they know that the services are available. We've provided at some tribal meetings in the past to share our services, but it's just an ongoing process.
Question just came in from John Miller. John, if you're okay, I'll ask. I'm Lakota. Do you run into issues with our traditions and spiritual issues? Not sure who that question was for, John. Are you in Texas? Trying to see you on the board, John, to see if you would like to ask this yourself. You might be on mute if you are here.
Okay, I'm off mute now.
Oh, there you go. Thank you.
Absolutely. I work primarily in rural areas here in Iowa, actually, as a mobile crisis responder. but I'm from Pine Ridge in South Dakota. So I'm just curious if you've got any backlash in any of the tribal communities that you deal with in providing mobile crisis work when dealing with the different spiritual beliefs and traditions of the tribal individuals. Because I know up on Pine Ridge, if we tried to implement something like we have in Iowa up there with non-native responders, it could potentially cause some pretty serious issues and not wanting to utilize those services. So I'm just curious if you guys run into any of that in the tribal communities you deal with.
I have not heard that, but again, I am probably removed, and so our local authorities would probably have that information, but I have not heard that.
And I can't think of any specific situations that we've encountered yet, regarding that. I mean, we do have, cultural competency training for all of our staff, including our MCOT team members, on an annual basis. And we go through and, determine which populations to focus on for that. And I think that helps. There's also part of that 40-hour training that the state provides to the crisis workers that, has us always at least mindful of the cultural considerations. But I'm not aware of any specifics with any of our tribal members.
And I'm not either. I know down in San Juan, they respond onto the reservation quite often, but I haven't heard them give feedback on those challenges, other challenges, as far as if someone needs a higher level of care, they don't have any options to get them to that higher level of care because they have different rules on the reservation. So there's challenges in that way, but it is a good question. And I'm not sure, I'll have to get feedback from the areas that do serve, that live by the Navajo reservation or the Ute tribe up in northeastern Utah.
Deb, did you want to say something?
I was going to say, this is just another example of really involving everybody in your region in some of the planning and getting the buy-in. Often, if you can find one or two champions on a reservation or, with some other populations, that can really help. From what I've been hearing, that the response, or actually the outreach by people living on reservations is fairly low. And, because I think they probably, manage to, deal with most issues internally, and or they don't have the awareness or the comfort in reaching out because they're not sure who else is going to respond. So again, I think it's an opportunity to try to get some better engagement.
I'm doing a time check. We officially end at 4:15 in 2 minutes. After that, we will stop recording and we'll be still available for 15 minutes for open, unrecorded Q&A session if you all would like to stay on the line. I'm going to throw out just for John, I don't know if you're familiar with Native and Strong, the 988 call line in Washington State. You might want to do a Google of that and see if there's context there that you might want to talk with.
Yeah, I might check that out because being a traditionalist and very active in my spirituality with sweat lodges, and I'm a sun dancer and all of that, and go to a lot of different Native gatherings, and having had conversations with some of the tribal elders, they love the idea of the service, but they don't like the idea of outsiders performing that service. For people that don't know about the Inipi ceremonies and the different things that they do. So I think that's a definite consideration if trying to get more involved with, because the tribal populations need it a lot, but they just, a lot of them, at least out on the plains where I'm from, don't want to accept it just because of who it comes from. So there's definitely a lot of, and I say it all the time, there's still a lot of hard feelings, I'll say, to say the least, between communities there.
And it's people like you who are aware, sensitive to that, are in those communities and practice many of the same practices that become the champions of developing our crisis services.
And I would
I-
definitely love the opportunity to go to like Pine Ridge and Rosebud and some of the ones in South Dakota and do something like that. But of course, I live right smack in the middle of a cornfield. So you know, you know, I don't even know if they have crisis services established in those areas of South Dakota yet.
Mhm, mhm.
But it's definitely something that is sadly needed out there with the, you know, there's a lot of hopelessness out there on the res that I'm from, and they could definitely use something like this out there.
Yeah, and people like you. Well, for all of those on the line, the over 100 people, if you are looking for someone like John Miller to talk to, you have networked with him today. And thank you, John,
I'm always here. I'm available 24/7
in the cornfield. But we'll
in the
get you out of that
cornfield.
cornfield.
I'll try and get out of the cornfield.
I'm going to do a time check. Actually, we need to officially end the recording of this, but I want to thank our presenters, Leanne Huff and Anna Ladumas from Utah, Lucrece Pierre Carr from Texas, Deb Kupfer from Wichita, residing in Colorado, and obviously Dr. Belinda Shaw, as well as our hosts, NASHBID and NRI. So thank you all very much for your time today. And at this point, we're going to stop the recording.